be here. Uh, Actually, my case is a 24-year-old lady from Sudan, and she was doing very well until 3 months back. She was diagnosed. She presented in Sudan to the hospital with fever, weight loss, and malaise. And echo was done for her. She was diagnosed as endocarditis, and blood culture was done for her. Unfortunately, there was no isolated organism, but there was vegetation in the echoes. She was started empirically on antibiotics for 6 weeks. Her symptoms subsided. But later on, she was presented to our hospital as her husband is working in Riyadh, complaining of shortness of breath and dyspnea for NIHA class 3, worsening over last month with lower limbs edema. On examination, she was looking pale, but not cyanotic. Her blood pressure was 100/70, saturation was normal, and heart rate was 80. GVB was raised, and cardiovascular examination showed systolic and diastolic murmur with lower limb edema. Her abdomen was distended with ascites. ECG was done for her with no specific finding. Her labs, as shown here, she has mildly elevated liver enzymes, and her chest X-ray showing biventricular enlargement with congested lung and pleural effusions. We did for her echo, and this is her parasternal long axis showing LV function. LV is mildly dilated. LV function is moderately depressed, dilated right ventricle. If you look here also, you will see that there is curve-like vegetation on the A2, and you can see also thread-like or elongated mass on the aortic valve, with color Doppler showing mild aortic regurgitation and eccentric flow of severe mitral regurgitations. This is the aortic vegetation. Also, there is poor coaptation of tricuspid leaflet secondary to annular dilatation with severe tricuspid regurgitations. Plus more, there is multiple masses and destructive pulmonary valves on the pulmonary valve. If you look carefully down,
even is aorta.
Yes, yes, this is the aorta. What do you see else? If you can predict this, you can see beta ductus arteriosus with the mass on it. So this is bilateral endocarditis secondary to the shunt, and the vegetation can be seen also on the patent ductus arteriosus. So this is the fourth chamber view and showing bowing of the interarterial septum with mildly impaired or moderately impaired RV, moderately impaired LV. And here you can see the continuous murmur with patent ductus arteriosus. So basically, this is a lady. She came with 4 valve destruction after endocarditis, and we have planned with the surgery team involved, Dr. Abdullah Ashmak, he's very senior cardiac surgery, for how to plan her management. And actually, the thought is that to go and replace almost 4 valves, then we reconsider that repairing 3 valves and replacement of 1 valve, which was done successfully. This is her intraoperative TE showing. Do you think this native mitral valve is normal, or do you think there is rheumatic process? Or I'm really doubting if there is any rheumatic changes or eczematous changes. Looks normal. It's not rheumatic. So you can see clearly the vegetation there and the severe mitral regurgitation intraoperative TE. And this is the patent ductus arteriosus with intraoperative TE done. Actually, she was asymptomatic. There was no fever. Her ESR and CRP was low. She was treated with antibiotics for more than 6 weeks. She was a bit stable. After decongesting her with the IV lasix and optimizing her hemodynamically, we took her to... So mitral valve was repaired it was reconstructed surgically and was repaired with a ring, and the A2 was shaved. The vegetectomy was done to mitral valve and was successfully repaired. This is post-repair view. And again, aortic valve and vegetectomy was done successfully. There is no residual AR even after the repair of aortic valve. And tricast as well, it was repaired with ring and leaflet reconstructions. And pulmonary valve was replaced successfully with tissue valve. PTA was ligated. It was combined surgery, adult and pediatric cardiac surgery was involved, and she was basically post surgery. She was doing well, and this is basically a case of 4 valve involvement with 1 valve replaced and 3 valve was repaired successfully, and with biventricular heart failure. 3 months after her follow-up, we called her yesterday, the day before yesterday. She was doing very well with no symptoms, no fever. She was even planning to get pregnant. So basically, my discussion or my message, which I have no really clue about 100%, is that should we consider that the PTA is still as a risk, non-cyanotic heart disease, is a risk or potential risk for endocarditis? Should we give based on geographical variations? My discussion is should we consider valve repair, endocarditis valve repair as a usual manner for endocarditis patient? I'm not sure. There is data about right-sided heart valve repair, but we don't have really good data about vegetectomy and in the left-sided heart. So, and the other things is the outcomes of vegetectomy or excision of vegetation post-endocarditis surgically. What is the data about it and what is the outcome? Thank you very much.
My case, I'm Dr. Rashid. I was working in Prince Sultan Cardiac Center, and then I shifted recently to KFMC. This case was, I saw him in BSCC. So he's a 30 years old male. As usual in our BSCC, our very chronic patient, multiple comorbidity, multiple surgery before. So he has rheumatic heart disease. Initially he had mitral valve repair 2000, and then after 4 or 5 years, he has redo mitral valve and aortic valve replacement. And then after another 4 years, he had another third redo surgery, mitral valve replacement, aortic valve replacement, and TV repairs. There is the third surgery because of severe paravalvular leak. So this patient presented to our ER with yellow discoloration of the sclera. He was jaundice and he is pale. He's not febrile. He has recurrent admission to Taif Hospital with anemia and heart failure requiring blood transfusion. So when he presented, his hemoglobin is 6. There's no leukocytosis. So this is echo done initially. As you can see, there is a mechanical valve, and there is very eccentric jet, severe leak, paravalvular leak. So this is a 3D, and 3D with color. You can see there is a mechanical valve. This is a surgical view. This is the aorta here, appendage here, interatrial septum. And you can see there is a dropout, tissue dropout here. Is it a real dropout or a paravalvular leak? You put a color, you can see there is a very eccentric jet, severe paravalvular leak. If you can, and then, so the patient was admitted for closure of paravalvular leak, and because of the 3 surgeries, there's difficulty in crossing the interatrial septum, and the procedure was postponed. After 6 weeks, he underwent fluoroscopy under fluoroscopy and TE guiding transapical approach. So this is here, they are doing at the same time a shot of the coronary to localize the exact site of puncture with assessment of our echo, so to be away from the coronaries. So they passed easily to the medial paravalvular leak, and then here they pass the wire, and then the guiding catheter. And here you can see, to be sure that you are in the hole, you can see that the jet is become less. After 4 months, unfortunately, patient admitted again to a Taif hospital with fever, short of breath, and his examination showed pansystolic murmur, and he had recent admission, as I said, with query infective endocarditis. They did culture. The culture came to be methicillin sensitive Staph aureus, and they mentioned that he has huge or severe dental abscess. So investigation again, hemoglobin is low. There is element of hemolysis, the LDH heretic is high. So what is going on here? So seen by the ID team as usual, we started on antibiotic, 4 antibiotic, and patient started and discussed in a combined meeting and accepted for a very high-risk surgery. And while he's waiting for surgery, after the antibiotic course, after like 3-4 weeks, suddenly he became short of breath. So T done agent, as I said, to see, so already T done, and this is the torrential MR, and you can see that there is something here roaming around, and it did all maneuver to embolize, but fortunately he has mechanical valve with a 2 disc that preventing this device to be embolized to the brain or anywhere. So all acrobatic maneuver done by this device, but fortunately cannot be embolized here and there, up and down, going to a bandage, going through the disc. Again, so this is our report. Dislodged one, hitting and unable to pass with some small vegetation. So patient went for urgent forced redo mitral valve replacement. So what is the role of echo in management of paravalvular leak? Yes? Huh? Okay, so echo is very important. 3D echo is complementary to 2D echo. There is, you have to include the landmark, and it is rare, but 1 to 5 will be symptomatic. The causes, the infective endocarditis, technical issues. The symptomatic, if you present with heart failure, anemia, and symptom of hemolysis. This echo is very powerful in this patient. You can see there's a tissue valve and there's multiple jet.
Bismillah ar-Rahman ar-Rahim. Thank Dr. Committee, organizing committee. Bismillah ar-Rahman ar-Rahim. Thank the organizing committee to give me this chance to present my case. My case is a 60-year-old male patient, with history of diabetes, hypertension, and dyslipidemia. He was seen in our outpatient clinic with main complaint of exertional chest pain and palpitation. Vital sign and oxygen saturation within normal, and patient was overweight, body mass index about 26, and jugular venous pressure within normal, cardiac auscultation was within normal, other systemic examination and remarkable. We did ECG for this patient was within normal, chest X-ray and remarkable, 24-hour Holter also reported normal, and exercise stress test was negative for ischemia. Then from cardiac imaging, patient underwent transthoracic echo, transesophageal echo, and cardiac MRI. Echo essentially was within normal, but we noticed there is a mass in the roof of the right atrium. And from parasternal from subcostal view. The intraarterial septum, there is a math appear here, so it's kind of focused on. Okay, and there is asymmetrical thickness of the intraarterial septum, proximal part compared to distal part. Okay. This is our transthoracic echo report, essentially with the normal, apart from large mass, measure about 23 to 33 millimeters seen in the right atrium. In some views, likely attached to intraarterial septum without hemodynamic effect. And lipomatous intraarterial septum hypertrophy is less likely due to absence of typical appearance of dumbbell shape. Then we proceed with transesophageal echo. Transesophageal echo also, so here there's a huge mass attached to intraarterial septum with asymmetrical thickness. And there is no evidence of flow obstruction from SVC to right atrium filling. Here by the color, there is no turbulence suggestive of any hemodynamic effect of this mass on right atrium filling. This is the math, measurement 25 by transesophageal echo, 2.5 by 5 centimeter. So our transesophageal echo report, there is a large homogeneous mass attached to intraarterial septum at the level of SVC with no evidence of hemodynamic effect. So next step, we have to proceed to know what is the tissue characterization of this mass. As you know, we proceed with cardiac MRI. Again, in cardiac MRI, there is asymmetrical thickness of intraarterial septum, and by T-weighted fat suppression, it was white here and became black. So it is clear that this mass due to accumulation of fat tissue. This is our cardiac MRI report, thickness intraarterial septum with spare foramen fossa ovalis, no classical appearance of dumbbell or our class shape of lipomatous hypertrophy of intraarterial septum hypertrophy, and the proximal part is more thickened than distal part. And by fat suppression sequence, this is nature of this fat is a fat accumulation. Conclusion, this is lipomatous hypertrophy of intraarterial septum, otherwise unremarkable. So our diagnosis for this case is atypical lipomatous hypertrophy of intraarterial septum. Lipomatous intraarterial hypertrophy intraarterial septum. It is firstly described in 1964 by American pathologist, Mr. John, and it is benign cardiac lesion, okay, due to fat deposition in intraarterial septum. Incidentally discovered in majority of cases, in asymptomatic cases, and the incidence about 1 to 8%, and female more affected than male. This number reported from cardiac MRI studies data, because during our daily echo, we cannot see this number. But MRI, as we know, it is more sensitive for tissue characterization. Etiology is not clear or unclear, and commonly found in elderly and obese patients associated with steroid use, emphysema, and diffuse fat deposition in other tissues like mediastinal or prominent epicardial fat. Okay. Characterized histopathologically, there is fat accumulation and despair of foramen ovala. The distinctive finding or classical finding of this lesion, it is hyperechoic global mass in the intraarterial septum, thickness more than 2 centimeters, and despairing of foramen fossa ovalis. The intraarterial septum appear as hourglass or dumbbell shape. Differential diagnosis, we have to consider all the fat containing neoplasm arise in the intraarterial septum, including cardiac myxoma, lipoma, rhabdomyoma, or others. Treatment, it is benign lesion. Majority of cases doesn't require any treatment. But in rare cases, here I am talking about case report in the website. Patient can present with arrhythmia disorder, SVT, atrial fibrillation, BVCs, OS, or presented with symptom related to flow obstruction of right atrium filling or SVC. including dyspnea, plus heart failure, syncope, or even cardiac death. In such cases, surgical excision with reconstruction of intra-arterial septum is indicated. Take-home message, lipomatous hypertrophy of intra-arterial septum may have atypical appearance of transthoracic echo or transesophageal echo. In such cases, we have to proceed with other imaging modalities for tissue characterization. And as you know, cardiac MRI is more advanced and sensitive for this issue. To differentiate this math, either benign or malignant. Thanks.
And this is a case of infective endocarditis. This is the fourth case about the struggle with the management. There is a lot of conflict between the surgeon and the cardiology. Discussion every day, go for surgery, no, I will not go for surgery until we see. So now we have two options for treatment, either to do an early surgery or just wait and see treatment and see what happened to this patient. So this is a patient who had a complication. This is a 74 years old man, had a bioprosthetic AVR 6 years ago. He is a cigarette smoker, hypertensive, and dyslipidemic on management, and he had also he presented to ER by 5 days history of fever. He was referred to another hospital and given antibiotic, not responding, came back to our hospital, and he complained of central chest pain. Somebody diagnosed him as SAS, but he's not SAS, his pain is atypical. Also, he had a complaint of diaphoresis, palpitation, shortness of breath, paroxysmal nocturnal. All complaints are there, but he denies any history of intermittent claudication or syncope. His past medical history was positive for hepatitis B. And then his family history unremarkable, and there is no past surgical history. Upon general examination, the patient was alert, vitally stable. He's hypotensive, 94/58, temperature 36.8, temperature is a little bit dyspneic, and he had the bilateral entry with right side crackles, and diagnosed with chest infection. Complete blood count was done, revealed 32,000, and serum cardiac enzymes are normal. Chest X-ray, bilateral infiltration, and there is a suspicion of community-acquired pneumonia. Blood culture was sent to this patient, and patient was admitted to the hospital, and his culture came with Streptococcus constellatus. This is persistently 3 cultures. And then echo was done. Echo was normal, but due to infective endocarditis, and this is prosthetic valve, so we did for him a TEE. Okay, you see the vegetation on the aortic valve. And so what do you think here to do? We discussed the case in the combined meeting, and the condition here is there is no valve dysfunction, there is no paravalvular leak or anything, and just go for medical treatment for antibiotic. And started already on ampicillin for 6 weeks. Length was about 7 centimeter at that time. 7 millimeter. 7 centimeter, it will go to the... Okay, nothing. Then infective endocarditis was diagnosed according to Duke criteria, 1 major criteria and 3 minor. The major criteria was an echovegetation, and the minor criteria was fever, culture positive for non-specific organism, and predisposing cardiac lesion, which is a prosthetic valve. Patient admitted was in the hospital for 2 weeks, and then we repeated the echo. The echo is here. Okay, so after 2 weeks of antibiotic, patient didn't improve. We thought that the vegetation will disappear or with the sludge or something. There is paravalvular leak and there is mitral regurg, and this valve start to dehisce. We repeated the culture many times. At that time, the culture was start to be negative. I will show you the cultures also. And there is an abscess also. There is an abscess cavity here. Yeah, this is an indication for? Yes. Okay. Okay, so it seems that all of us are cardiologists, no surgeon here. That's good. لا, no. So this is an abscess, a proven abscess, and it is worsening. In spite of antibiotic and fever disappear and culture becomes negative, still we have complications. Okay, so this is again a tissue valve, tissue bioprosthetic valve. Okay. Type. This is a fixed picture. Okay. Then the patient we discussed in the meeting, in our meeting, departmental meeting, and the case was declared unfit for surgery. Why? The reasons, and they stated old age, 74 years, liver cirrhosis, referred to gastro, and he has a child C class, and also he had multiple brain cerebral microbleeds. So he had some bleeds in his brain. That's why the surgeon refused. Yes. Okay. So this is the first surgeon. We discuss again with another surgery the same story. His blood cultures you see in September, and at the end of it is all, most of them are negative, and now we need to do something for these patients. Okay. Then we repeat it, we continue the antibiotic for another 2 weeks, and what will happen here? It is about khalas, dislodgement. Discuss with another surgeon and third surgeon, and they still refusing to do anything for these patients because of his high risk. Actually, we are in the Saudi Heart at that time, and most of the consultant, one sharing session and the other speaking here, and I was there in the echo department, echo conference. And then this is the situation. So the suggestion to sign no code and to leave the patient. I told him, no, we cannot accept this. This patient is alert, conscious, go over everything. We cannot do anything. We cannot ignore this. We have to take him for surgery. Then finally, one of the surgeons accept to go for high-risk surgeon. Okay. TE repeated. This is the TE. So he took him after high-risk surgery, but he requested, he said he's scared from bleeding in the brain or in the GI because of hepatic child C. So while we was in Saudi Heart, what happened? This is the fellow sent for me an ECG while I was attending a lecture of Dr. Tariq Al-Hussein at that time. Yes, and what happened here? He had a segment depression and he started to have chest pain, severe chest pain. That's why the surgeon went to the hospital and he operated on him at that time. This is his intraoperatively. The patient, they told me that the valve is about to dislodge. It is only with few fibers attached to the body. And then he make a new technique. He told me about this technique, exercises, abscess, and he did the coronaries and everything. And patient already shifted to the intensive care unit. And but in the night he had developed tamponade. They took him again to the surgery, and then he recovered. So what is the message here? Streptococcus constellatus. We don't know. We hear also another streptococcus today. Also, you have something else. The culture was negative 3 times after. 2 culture or 3 culture, and this is by ID team. So patient discharged in stable home. Do you think this patient is okay? Is he still living, or what happened to him? He's my friend and he's my close friend. And so now what is the best option in this complication? To go for early surgery, and how early is it? After 2 weeks, or immediately to go for surgery, or wait for the complication to happen? And from I reviewed, there is high mortality for prosthetic valve surgery, increased risk of treatment failure, significant complications. And here, because of lack of data, we have to go centered approach according to the comorbidities. And this is the AHA indication for surgery. And class 2B to have a cardiology team, a heart team, including the neurology, the infection, the control, the pathologist, and microbiology. Thank you.
Assalamu alaikum. It is my great pleasure to be with you, my colleague and the professors. Inshallah, rapidly كده, I'll present one of the rare adult congenital heart disease. Our case is 30 years old female with no significant past medical history, came to our clinic with infrequent palpitation, shortness of breath for a long time, but she didn't seek any medical advice at all. On examination, her examination was unremarkable. Just we found continuous murmur 3/6 over left sternal border that propagated to the right sternal border. So primary we did ECG and the chest X-ray for her. Her ECG was unremarkable, also just for premature atrial beats that could be for anything rather than cardiac issue. But chest X-ray shows atrial enlargement, especially right atrium, mild exaggerated bronchovascular marking. So this gives us one clue to do echo for her to delineate any problem, any cardiac problem. And this is echo. Atrial enlargement, special right atrium, mild tricuspid regurgitation, but we found a membrane-like structure inside the right atrium. This membrane-like structure inside the right atrium that divides the right atrium into two chambers that connected with each other by fenestration, indicated here by color Doppler. First impression for us was core triatriatum dexter. This is the first impression for us. But with this next view, we found here a tunnel-like structure arising from the aortic root, directed anterior to the right side, and the flow is passing from the aorta side to the other side. Here, in short axis, we found this tunnel is arising mainly from the right sinus valva, runs anteriorly, then I think it is coming into the right atrium, enters the right atrium with aneurysmal formation, then opening into the right atrium by a fenestration or something called isthmus. So we request a transesophageal echo for delineation of the problem and get more data. For transesophageal echo, we found this one also. This is a tunnel-like structure arising from the aortic root, right sinus valva, directed anteriorly, and also flows passing in one direction from the aorta side to the other side. And here in bicaval view, we found multi-lobed tunnels inside the right atrium with almost the color passing inside, continuous color passing. There is no phases. But here we can't find the opening into the right atrium or the origin from the aorta side. With some modification of the view, we found this. Here's the tunnels arising from the aorta, directed anteriorly, looping, enters the right atrium, aneurysmal formation. Isthmus about 0.6 centimeter, 2D measuring also. And here's a contrast bubble study. We wanted to detect any other congenital aneurysm-like connection between both atria, flows passing backward to the tunnel like this, but we didn't find any connection, and no flow inside the tunnel passing totally. That indicates the flow is coming only one direction from the aorta to the right atrium. And here the 3D view over the bicaval view, we can find here this is the tunnels, multiple inside the right atrium. Color flow is passing here also. So we wanted to be confirmed this is aorta right atrial tunnel or not. Yes, we did CT. We did CT, and this is data we collected from the CT according to the CT radiologist. Normal aortic root, right sinus valva gives origin to large tortuous aorta right atrial confident ectatic long tract, right proximal aortic ostium that measured about 17-16 millimeter in cross-sectional area. Tunnel runs through the right atrioventricular groove, showing relatively big phenomenon with multiple ventral segment that end at the posterior inferior wall of the right atrium by narrow distal isthmus that measure about 6 by 5 millimeter in cross-sectional area. Right coronary artery is seen dominant, moderate in size, depending on the tract, originating about 30 millimeter from the aortic ostium. Its origin is anterior from the tract, intermittent to VDA and VL. system, left coronary system, is normal, with no any continuation between the left system and the cardiac cavities. And here, this is the CT image. We can see here the right side of the valve. This is the opening or origin of the tract, runs anteriorly, looped back, runs into ventricular groove, aneurysmal formation, looped again, enters the right atrium, and inside the right atrium, as we saw by transesophageal echoes, this is multiple zip opening. And unfortunately, this is the best image. I send the CT image for many centers to get image and no rendering. والله انا حاولت معاه كتير جدا والله بس هو ده انا عشان So our diagnosis is aorta right tunnel management is the surgical closure as the RCA is dominant on the tract. Sometimes we can do transcaster closure by coil or something like this. We talk with the patient about the complication, volume overload and visual formation, 50 cardiac after that. He didn't accept surgical plan and aorta right. Aorta. Right coronary arising from the tract itself. She's so it will be reimplanted again in the aorta. Review of the literature. 30 years. 30 years.